Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're going to talk about genetic testing during pregnancy and preconception. I know there are a lot of tests out there, and sometimes you don't know which one you should get, when to get it. Maybe you're confused about which ones are more invasive and less invasive, and even what to do when you hear results, and maybe you're questioning how accurate they are. So to dive into this conversation of prenatal and preconception genetic testing, I have Kira Dineen. Let me tell you a little bit about her. Oh, she's got so many letters next to her name. Let's dive in. All right. So MS, LCGC, I believe that stands for Licensed Certified Genetic Counselor. She has CG with ASCP. Oh, my dyslexia was really having fun with that one. Anyway, she is a licensed certified genetic counselor, and she has been specializing working with pregnant folks and helping people plan pregnancy to obtain family history and explore genetic testing options. She's also the host and has produced 7 podcasts. Her main show is called DNA Today, and it is excellent. So Kira helps demystify a lot of the genetic tests out there and helps people make decisions on what's best for them. She is incredibly fun. I had such a great time. Even though this can feel like a very heavy topic, the way that Kira explains that and her enthusiasm, I think will help set you at ease and also help you have some clarity around genetic testing during pregnancy and preconception. So I know you're going to enjoy this. Before we get to that conversation with Kira, I just want to give you some heads up and some updates about what's happening at Prenatal Yoga Center. So by the time this drops, we will be having our new online, it was actually on-demand childbirth education class out there. I am so excited for it. So it is led and produced by my friend Terry Richmond, who has been on the podcast, 3 or 4 times. She is an amazing childbirth educator. She is a doula with 20 years experience. She was my doula at thousands of births, and she put together this amazing on-demand childbirth education class. So take a look at that in our on-demand library. We're continuing to offer prenatal classes online 7 days a week, so you can jump in no matter if you're all the way in Australia or just in Astoria, wherever you are, you can take class with us online. And of course, in person, 6 days a week. And we still have our Baby and Me and our postnatal classes. And as this is being released, we've now finished up our in-studio, I guess it's early spring, late-ish spring, teacher training, prenatal teacher training. So my brain thinks in school years. So we do 4 a year. We do September, October, November, December, January, February, March, April. And we're just finishing up this school years of teacher trainings. So if diving into our methodology is something that excites you, check out our website, prenatalyogacenter.com, to see if you are able to take one of our in-studio prenatal teacher trainings or online. And then once a year, we do an online postnatal teacher training. You can check that out. This year, it is May 20th and 21st online. All right, and if you happen to pop over to our website, make sure you grab your free downloadable. It is 5 simple solutions to the most common pregnancy pains. So if you're feeling all aches and pains, we got you covered if you can't make it to one of our regular classes. And then the last thing I want to say is thank you. Thanks for being a listener. Thanks for being part of our community. I always appreciate your input. If there's a conversation I haven't had, let me know. I want to find that conversation to have to better support you. Maybe there's a speaker that you think would be great for the podcast. Have them fill out one of our applications. All right, that is enough of me. Let's take a quick break and come back, and you're going to enjoy my conversation with Kira. Hi, Kira. How are you?
Good. How are you doing, Deb?
I am doing well. So I'm all about full transparency with our community. It is 8 a.m. and we are doing this podcast.
Yes, it is 8 a.m. It's the first thing of the week. I've got the coffee going. And so I'm going to try to sip while you're talking. So it's an art as a podcaster, but I'm going to do my best.
Oh my gosh. Yeah. This is the earliest. I'm wide awake. I got my coffee. I got water. We're good to go. But I find it kind of humorous when I told my husband, I'm like, we have an 8 a.m. podcast. He's like, are you kidding me? I'm like, nope, that's what we do. Anyway,
I feel like, yeah, Kira couldn't do the normal time. So she had to be special and,
very special.
And start your day off with this. So no, I appreciate you being flexible.
No, I'm thrilled. I'm really excited. So I had done a podcast on genetic testing like 6 years ago, and I'm sure things have changed. And it was one of our most listened to podcasts, and people have been asking for kind of an updated version. So I'm so excited to jump into this with you because I know when I had my babies, it's been a bit. It was a little nerve-wracking to work with a genetic counselor, especially because I was what they called a geriatric pregnancy. I did not appreciate that term.
Lovely term, isn't it?
It was really very stressful, that whole situation. Not the pregnancy, just the genetic testing and the counselor. So I'm really excited to dive into going into this. I guess before we get into the deep end of genetic counseling and genetic testing, I'd love to learn a little bit about you and what led you to focus on genetic counseling.
Sure. Yeah. So I learned about genetic counseling a lot earlier than my peers. So I learned about it in high school. So I had a lot of time to set myself up to, prepare myself to go, apply to grad school, get into grad school and all that. So I think it's helpful to know my mom is a social worker. So I grew up with, her sharing a lot of, obviously, HIPAA and everything, but sharing client stories and different things and different approaches of CBT, DBT, so cognitive behavioral therapy, dialectical behavior therapy. And so just being exposed to a lot of counseling, I was like, well, this is really cool. My mom has always just felt that her career is very rewarding. I don't know if my mom will ever fully retire because she just loves what she does so much. And I really wanted that for myself. I wanted a career that I felt like I was giving back and that I was really engaged with. And so I really admire my mom and her career, and I just see how well that's gone for her. And I was like, okay, it's not quite nerdy enough for me. I'm like, I need another aspect to it. So, my mom was like, I found your career. And I'm like, okay, Mom, what is it? Right. And she was like, genetic counseling. I'm like, what the heck is that? So, I learned at that point just that, being a genetic counselor, you get to help people understand genetics and how it affects them and family members. And I always found genetics to be interesting from, 7th grade, I think is the first time. And I grew up in the Connecticut public school system. And so that was the first time I think we were introduced to genetics. And I just thought it was so cool. And just that there are so many things we didn't know about genetics where I'd ask a question and they're like, well, we don't know yet. And I'm like, well, that's cool. So we'll find that out, if I stick with this in a career. So, it all kind of came together. And so, here I am 10 years-ish later. And just now I work with pregnant people, as you alluded to, and helping them understand the genetics of their pregnancy. And if there's any genetic conditions or anything we should be aware of that their biological children may inherit or could come up. That's kind of just how I got to where I am today.
Oh, I'm so excited to dive into this. So I guess let's start kind of in the beginning of what is genetic testing and what are these tests looking for?
Sure. So there's two main tests that I think we should chat about. So the first test can actually be done prior to pregnancy. So prior to conception or during pregnancy, which is when the vast majority of people do it. And this is called carrier screening. So what carrier screening is looking at certain conditions where if someone is established as a carrier and their partner is also established as a carrier or their sperm donor, depending on different scenarios, then there's a chance if they're matching for a condition like, let's say, sickle cell, cystic fibrosis, Tay-Sachs, any of these types of disorders, then there's a chance that baby could inherit that. So it's a 25% chance at that point. Now, most people are a carrier of some condition. It took me about 500 conditions looking at to find one that I was a carrier of. So, and I expected that. I'm like, I'm a carrier of something. I just got to do enough tests to figure out what I'm a carrier of, just statistically speaking. So, in my future, I'm in a same-sex relationship. So eventually when we look for a sperm donor, I'm going to make sure as I choose a sperm donor, if we're using my egg, that we're not going to choose a sperm donor that's a carrier of the same condition. So, a lot of people are having a biological child with their partner. So in that case, we're looking at, okay, if you are a carrier of the same condition, let's chat about that. And I love when we can do this before someone's pregnant because it's way less stressful to say, okay, if you guys have a kid together, then there's a chance, this 25% chance that you could pass this on to baby. Let's talk about the options at this point, including IVF, in vitro fertilization, where you can actually do genetic testing during that process, add it on, and test the embryos to say, okay, which ones will have this condition? And if you're lucky, you have a lot of embryos, you have some that are negative, you could choose to implant that negative embryo. Alternatively, you could.
Fascinating. I didn't even think about that. I'm like, well, as you were talking, I'm like, well, what do they do if they find that both people have
right?
that? Okay.
Yeah. And most people don't hear of this. And so we're doing it while they're pregnant. I'm so excited when I have a preconception on my schedule because I'm like, that means that we're going to do carrier screening. So, or at least talk about it, right? So anytime I talk about a test, I'm like, hey, let's chat about this. I want you to understand this and then see if it's a match for you. I don't care if someone does the test or not. My job is kind of like a guidance counselor to say, here's your options for college. I don't care where you go. I just want it to be a good setup for you kind of thing. So there's also, for most of my patients that are pregnant while they're doing carrier screening, if they find that, okay, we are matching for a condition, there's still options there. So we can do testing during pregnancy to say, okay, did baby actually inherit this or not? To have a little bit more information at that point, for different decision making. So, it's great. I think if someone came to me and said, hey, I'm planning on having kids soon, is there anything that I should do now? I'm sure, MFMs, OB-GYNs, like they would say a lot of things, but my thing is carrier screening because I'm in the genetic space.
Right. Now that makes sense. All right. So I'm kind of deviating from the plan I had for our conversation. So say somebody, I knew you would. Because my brain is like spinning on this. So say someone did not do a carrier screening therein. When would somebody be doing these screenings to find out, like what's the timeline?
So if they didn't do a preconception?
Yes.
Okay, sure. So, the way that it works in the practice I'm at is everybody meets with me at 10 weeks of pregnancy. So that's because of the other test we'll talk about. But as soon as I meet with people, I offer them carrier screening. So, if they're already pregnant, a lot of people will meet with a genetic counselor or someone that provides information about genetic testing. So that might be the doctor. That might be one of the nurses. So, it's great when it's a genetic counselor, but sometimes nurses are also very well versed in this testing. It definitely depends. But I find, somewhere there in the first trimester is common to then have the carrier screening.
Okay. So
at least offered to you.
I definitely want to talk about the other screenings that happen around 10 to 12 weeks, but let's keep going on this carrier screening. So say somebody did not do it preconceptually. They are 10, 12 weeks and now they're doing it. What are their options should they see that they and their partner are a match for something?
Yes. So I think this is where the processing about it is important and that counseling aspect, because I want to know what they're thinking and what their options are in terms of what they're open to. So if someone says to me, I understand, we talk about what this condition is, either it's mild, it's kind of moderate, it's severe, like what is this condition? Is there treatment for the condition? So kind of going over all that information and then talking about, okay, well, we could test baby to see, did baby actually inherit this? And what that involves is an amniocentesis. So for an amniocentesis, this is an invasive procedure. So it's certainly a conversation. And for people to understand, there is a risk of miscarriage with the procedure. It's very low risk, but it's still a risk.
But that's done, isn't that done like 20-ish weeks? Maybe I'm wrong. I could be off.
Yeah. So that's done typically 16 weeks and later.
Okay.
There's another procedure very similar called a CVS, chorionic villus sampling. And so this is basically taking a biopsy of the placenta. So that can be done earlier. That can be done right kind of the end of the first trimester. So depending on where someone is and if it's carrier screening, those, as I mentioned, like cystic fibrosis, sickle cell, Tay-Sachs, Duchenne muscular dystrophy, Fragile X. So all those kind of conditions, most of those that I mentioned are autosomal recessive. A couple of those were X-linked, so they're kind of the exceptions. But for those, a CVS is certainly an option. So it's kind of when I'm talking with families, you know, the person, their partner, their mother, whoever's involved in the pregnancy, it's kind of saying, okay, well, is this information you want to know? Because some people are like, well, it doesn't change anything for me during pregnancy. I would rather just test after baby's born. And that could be because if they found this out, they wouldn't prepare any differently to have this child. They may not personally have termination as an option for them. So it's helpful for me to talk and understand. Some people would say, well, termination is not an option for us. However, I want to do this testing because I want to take the time during pregnancy to learn more about this condition, identify doctors and other healthcare providers that are going to be really important in this
and
child's
mentally
care.
Prepare and be like, okay, this baby comes, here's your support to help baby.
Exactly. And have testing like lined up to then confirm it. Some people might want to do that after baby's born. Meet other people and families with a child with this condition or an adult with this condition. Start learning about the community that's around them, you know, either geographically or obviously, just, you know, throughout podcasting, internet, social media. So there's a lot of things that people will say, well, I don't want to do testing because I wouldn't ever terminate. And I'm like, okay, that's very helpful for me to know. But there's also other reasons to do the testing,
right?
Like preparing. So I think that's a, you know, kind of a, not a myth, but something that I want people to understand of, you know, if you're getting one thing out of this interview, I want guys to understand that meeting with a genetic counselor does not mean you have to do testing. It's just to learn more about it and see if it's a fit for you.
No, I'm excited for this conversation because I think you just gave people a lot of information, and I'm such a preparer that I would be that person to be like, okay, baby has this. Like you said, I want the community. I want to do the research. When baby comes out, I want to hit the ground running to best support this baby. So I really appreciate that point. All right. So let's get back a little bit to kind of what are the basic tests? So besides a carrier test in like that 10-ish week, what else is happening in that first trimester that most folks are getting?
Yeah. So most pregnant people are offered something called non-invasive prenatal screening. So NIPS goes by a lot of names, NIPT, NIPS, NIPID. I mean, I've heard so many different, you know, acronyms and ways to say it. So really what this test is, the science behind it is really cool. So we'll nerd out for a second here. So they're coming off someone's placenta, our cells, and the placenta and the fetus share DNA. In the vast majority of cases, it's the same DNA. So it's different from the pregnant person. Isn't it so cool? Remember when I learned that? And I was like, oh, that's interesting. Like I always kind of thought like, you know, earlier, like, oh, the placenta's like, you know, the pregnant person's DNA. But I was like, no,
made
actually,
I guess it's the baby. That's so cool.
Exactly. Yeah. So when you have like an embryo, part of the embryo becomes a placenta and part of it becomes the fetus. So during pregnancy, you have cells coming off the placenta, going into the pregnant person's bloodstream and popping open and releasing their DNA. So another name for this test is called cell-free DNA because that's what it's looking for. So this is non-invasive, as the name of the test points out. And what you're doing is you're looking and you're just doing a normal blood draw, usually one tube. One company requires 2 tubes. And then when it gets sent off to the lab is able to, depending on which setup they're using, they're basically able to look at the pregnant person's DNA and the placental DNA, aka the pregnancy DNA, and look to see, okay, now we're looking at random conditions. So before with carrier screening, I was talking about inherited conditions. This is the other bucket of genetic conditions where it's random. So Down syndrome would be the most common one that comes up. So these are, for most of these, they're extra or missing chromosome conditions. So Down syndrome is having an extra chromosome 21. And then there's other ones, the more common ones, having extra 13, 18, having differences with the sex chromosomes. So those are the more common ones that come up. And really everybody in the United States should be offering this test because the American College of Obstetrics and Gynecology recommended in August of 2020, so right as kind of pandemic was going, said, okay, everybody should be offered this test.
So is this
there's a couple
instead of the
other
nuchal
tests.
test? Because I remember having that. Again, my kids are now 9 and 11, so it's been a minute.
Sure.
But is this instead of that nuchal test that they used to do?
So it's kind of an addition. So
Okay.
the nuchal translucency, so that's specifically the ultrasound that's done at right around 13 weeks. So kind of right as you're ending that first trimester. So the testing that you were probably offered is called first trimester screening or quad screening. So that's, instead of looking at the DNA of the pregnancy, that's looking at protein levels and saying, okay, we expect to see this kind of pattern. If it's different, we say, well, usually if it's this abnormal pattern, we're thinking it could be Down syndrome. So that's been very helpful for decades to have that information. But right between your kids is when this new testing was available. So about 10 years ago. So that's when I started the podcast. So that I host DNA Today. And so it's cool that we kind of started the same time as this technology because it helps me keep track. But yeah, so it's really great because if you're comparing the other tests that you probably had, the first trimester screening, like those protein-based tests, the statistics aren't as good as with this new NIPT test, just because we're looking at DNA versus protein levels. So just looking at that, you're like, well, yeah, that makes sense. If you're actually looking at the DNA, it's going to be better at finding disorder, like genetic disorders, because you're looking at the genetics.
Right. No, I think that's fantastic. So how much more accurate is it for things, or is it just different?
So looking at it, if I have someone that did first trimester screening and it comes up, okay, high risk for Down syndrome, the chance that is a true positive, that baby actually has Down syndrome, is less than if I do it through this non-invasive prenatal screening, the NIPS. So typically when I have someone do this newer test, the non-invasive prenatal screening, they give you a personalized percentage to say, well, what's the chance for this pregnancy baby actually has Down syndrome? And one of the other factors with that is actually looking at how old the person was when they're going to deliver the baby. So as we talked about, geriatric pregnancy, we're trying not to use that term as much. Now we use advanced maternal age, which I don't think is any better. And then we start getting into gendered a little bit.
Yeah.
So I'm like, I don't know, baby steps. But yeah, so they're taking that into account too. The first trimester screening does as well. And for people that did IVF, it's looking at how old were you when you retrieved the eggs, because you're literally freezing those eggs in time. So if you had, eggs retrieved when you were 28 and now you're pregnant at 38, we get to use that 28 number. So I'm kind of bouncing around a lot here. So, but yeah, so it's definitely, if you get a high risk result, it's more likely to be true with this newer testing than with the older testing.
All right. I want to keep going in that direction. We're going to take a quick break. When we come back, let's keep digging into the accuracy of that. So we'll take a quick break. We'll be right back. So since this has a higher rate of accuracy, are you not seeing amniocentesis involved with pregnancy as much?
Oh, you got it. Yep. Yeah.
Which is great because, as you said,
which is great.
There's a higher risk, like there's a slight risk of miscarriage with it. So it's more invasive.
Right. So, and the risk that we quote just in the American literature is 1 in 400 to 1 in 800. So it's kind of in there. So it is a low risk, but still anytime that's a risk, people are hesitating, as they should, of just thinking it through and saying, do I really want to do this? But yeah, as you said, a lot less people are doing amniocentesis or a CVS, kind of looking at both of them together as being invasive tests, just done at different points in pregnancy. So, but we're doing this so much less because we're not having as much false alarms where a test comes back, says, well, there's a high chance for this condition to be there. And then it's like, oh, okay, actually that was a false alarm. That was a false positive, right? So that's one of the wonderful things about this. Now, the flip side of that means a lot of these newer OBGYNs, MFMs, if they haven't been in the field for that long, then when we are faced with doing an amniocentesis, some of these younger people that haven't been in the field as long, they aren't as, they don't have as much experience in doing these tests. Mm-hmm. So I think that's one kind of downside that I've thought about over the years. I'm really lucky that I work with an MFM that has been in the field. He started the practice the month I was born. So, so I always know exactly how old the practice is. So he's been working for decades. So he's done, I mean, I think probably last time we counted was like 3,500 procedures, wow. Of a CVS or an amniocentesis. So I'm really, really lucky to work with someone that is, so experienced. And we have people coming to us from other practices just because they know that.
Right.
So I think that's just one thing for people to consider. And, if I was pregnant, which I hope to be in the kind of distant future, but one of the questions I would ask is if I was looking at doing amnio, it's like, okay, well, how much experience do you have with this? Because that's going to change that risk for a miscarriage with how experienced is the person performing the procedure, which just makes sense. That's the case for any kind of procedure, right? You go in for any kind of surgery or your loved one goes in, you're researching that doctor. I'm always looking, type the person's name, lawsuit. Like, is there anything I should be aware of,
Smart.
So yeah, I think that's one thing to consider, but, overall, obviously for patients, it's a great thing that we're doing much less amnios and because of that, we're only really doing amnios when a condition comes up. Sometimes people will say to me, everything looks negative, beautiful, but I know the amnio test for more conditions. And it's a test versus screen. So some people might elect to do that, but it's only a couple a year. I see about 500 patients a year. So it's only a couple that end up going that route.
All right. So I want to circle back, make sure people understand the basic genetic tests. So there's the carrier test, is it NIPT or NIPT? I'm not sure.
Yep. Okay. Yeah, I usually say NIPS.
Okay, so there's that, and you said people are still doing the nuchal test around 13-ish weeks. Okay, what other kind of basic? And then I want to go into what are the tests as people get older. So I want to make sure we covered our basic. Did I hit the main three, or are there more basic tests?
Yeah.
Okay.
Yeah, definitely. And to note for the ultrasound, we talked about the nuchal translucency. You still perform that ultrasound with the NIPS. So that's a great setup because you still want to look at ultrasound. It's not like the blood test is replacing, the ultrasound. That's still very valuable to have. And looking at, the nuchal is looking at how much fluid is the back of the neck. So a little bit of fluid is normal. If we see a lot of extra fluid, that's a finding for us where we say, now we're more suspicious for a genetic condition there. So yeah, still very, very helpful. I haven't had a patient decline doing that ultrasound because there's nothing invasive about it, just an ultrasound.
All right. So then that's your basic for your average pregnant person. But what about when someone passes that magic 35-year-old number? What happens then?
Yes. Right. And people think, as soon as I turn 35, things like dramatically change. It's like, we had to pick some number to say, okay, the risk goes up at this point. And in reality, the risk is going up a little bit every year. So it starts going up that trend, if you're looking at it on a graph, like the line starts going up a little bit more steeply once you're around 35. So I think, if someone is 35 or older, at either when they retrieved the egg or when they're giving birth, it's helpful to know, okay, that your chance of having a baby with Down syndrome is higher at this point than if you were 25 or something. So I think that's just a helpful concept to just be aware of. Sometimes when I'm talking about the test we were talking about, the NIPS, sometimes maybe someone's on the fence about it. And then we talk about, well, what's the chance right now, just statistically speaking, that baby has Down syndrome or another one of these conditions. And then sometimes looking at that number, they say, well, okay, now I feel like I want to do the test. Most people do the test from at least my patient population. I'm kind of New York based, right outside. But that is the most relevant test because we're looking at random conditions that increase the risk as someone gets older. So that's really honestly the main test when we're looking at genetics.
So it's not necessarily additional testing. It's just the fact that the percentage of possibility goes up.
Yeah, definitely.
I remember going in. So I had my first at 37, my second at 40, and I was with a different genetic counselor, and she had this like old school, like Rolodex looking thing. She's like, so when you had your first child, here were your options and here was your percentage. And then she flipped it and she goes, and here they are now. I wanted to be like, I'm pregnant. Like it's not going to change. Right. Thank you for, she was like, boom, here it is now. And the percentage just looks so big. And I'm like, well, that wasn't very thoughtful. So I guess
I try to avoid that.
I'm very glad to hear that. So it's okay. So again, it's not additional necessary testing. It's just percentage. Okay.
Right.
That's
you
helpful.
might be more motivated to do the test looking at that. I have some people that are, I would say most people nowadays that are having babies, at least, being in New York, Connecticut, most people having babies, I find, are in their late 30s, early 40s. Honestly, I'm always surprised when I have someone I don't check off that advanced maternal age box.
Right.
And I'm like, oh, wow, they're young. I'm just like, wow, that's an exception. But just to kind of normalize it, I feel like most people, millennials are just having kids later than the generation before us. So, like I'm planning on having kids when I am AMA because I feel like that's going to work out best for my life and finances and just, living my life before kids and all of that. So
totally recognize
definitely try to normalize that. And I don't bring it up to patients, honestly. If they ask about it and they say, well, what's my chance? Like, I'm 36 or I'm 42. Like, what's my chance? Then we'll get into it. Or if I see that if I feel like they're not grasping the test and really getting, okay, like, they're looking at Down syndrome and they say, I'm okay. I'm like, okay, let's talk about this a little bit more. And maybe at that point I would bring up a statistic, but I try to avoid that because I'm like, as you said, it's like they're already pregnant. It's more just as long as I understand that I feel like they understand the testing and they're saying, no, I don't want the test and they get it. I'm like, all right, cool. I don't care. As long as I feel like they're understanding, then I'm fine.
No, I appreciate the way that it seems like you support your clients and your patients. So I want to circle a little bit back to the amniocentesis. Can you describe what that is for those? Because we're kind of on that, late maternal age, and that maybe those people are feeling like they want an amnio, maybe, who knows? But I want people, should that be something that's brought up to them to understand what that whole procedure is like? Because it's, as we've mentioned, it is more invasive than some of these other options.
Yeah, definitely. So, and as we said, people that are looking at maybe doing amniocentesis may have had through one of these genetic tests we talked about through the carrier screening or the non-invasive prenatal screening, could have had something come up where now we're saying there's a higher chance that their pregnancy has a condition from one of those screenings. So if that's the case, then, I'm sitting with them and talking about, okay, well, this is the test we can do. And instead of looking at what is the chance, we can say yes or no, baby has this condition or baby does not have this condition. So that's how it's helpful. As you were asking, the way the test works is we do an ultrasound, just take a look at baby, look at where baby's positioned. That's really important. We're using ultrasound the entire time we're doing the procedure so that we're not going in blind. And I personally don't do this procedure. I talk about it and I answer questions about it. But the doctor I work for does the procedure. So it is a doctor doing this. Your genetic counselor is not performing the test. They might be present, during it if you so choose, or depending on the setup of the practice. So when you're actually doing the procedure, after we do the ultrasound and we cover all the questions you have and everything, we'll numb the area on your stomach. If we're looking at an amniocentesis, this can be done two ways. Most people do it through a needle through the stomach. So we numb the area for your skin. Now, we can't numb further down. So and I have not had this procedure since I haven't been pregnant. But what patients describe to me is that when the needle goes through the uterus, you feel like a period cramp. And that happens because the uterus is like, oh, foreign invader, we got to protect baby. So it kind of cramps up to be like protection, right? So yeah, they describe it kind of like a period cramp. The needle is only in for, I would say, between 30 and 90 seconds. So the actual procedure itself is very short. It's more of just the setup, cleaning the area, making sure everything, we're all clean using aseptic technique and all of that. And what we're doing is we're taking a little bit of the amniotic fluid. And the reason we're taking amniotic fluid is because as baby is in utero, baby is drinking and peeing the same fluid over and over and over, also shedding their skin cells. So by taking a little bit of the fluid, we're getting baby cells that are floating in this fluid without actually touching baby. So we're not touching baby during this. I think that's an important thing to get. And so then we take this fluid, we send it off to the lab, and they're able to look at those cells for whatever tests we're ordering for that. So the procedure itself, is a few minutes, and most people end up saying, oh, that's not as bad as I thought it was going to be. That's what most people say to me. But again, that's just from relaying other people's experiences there.
All right. So I might be asking a follow-up question that we don't know the answer to, but you did say there is a slight chance, I don't know the percentage you mentioned, of miscarriage. What would cause that from the needle going in?
Sure. Yeah, good question. So, and that chance is about 1 in 400 to 1 in 800. So that's really going to depend how much experience the provider has. And, I think different situations there.
And
that's not nothing, right? Yeah. I mean, it's less than a percentage, but still that's certainly a consideration. And I certainly have patients that say, you know what, we're going to decline doing the amnio because of that reason, which is completely valid. I totally understand that. So in terms of what actually causes the miscarriage, oftentimes, so we are poking a hole in, right? And vast majority of cases, that hole is closing up. Mm-hmm. Sometimes it doesn't close. And so we can have fluid leakage. Yeah. An infection sometimes. So if we have amniotic fluid leaking and then we don't have enough amniotic fluid, that can be dangerous because the amniotic fluid is really just helping bubble wrap the baby kind of thing. So,
also it's like when we talk about in birth that once someone's water breaks, we don't want really anything going up there because of infection. So if somebody, if their amniotic sac did not re-adhere and they're going about life, I could see how that makes sense. Now I'm putting the pieces together.
Right. So that would be the main reasons. There's a couple others and everything, and that's why afterwards, when you're recovering, we say, whoever your support person is, like they get to, wait on you hand and foot. You're going to watch all your Netflix, Hulu, HBO Max, whatever you got going on, and just really take it easy that first 24 hours. And then, just kind of, you can step it up a little bit for the next 24 hours. And then by 48 hours after your procedure, you're just kind of back to normal. And that's really just, to help minimize some of those risks. But it's also so that you experience less cramping afterwards. So your uterus is kind of like, what was going on? So your uterus is like trying to figure out what's going on. So if we have you just chilling and just on the couch, on the bed, whatever, then you'll experience some cramping. But if you are more active, like especially exercising, like we really advise against that, then, you're more likely to have even more cramping. So we're also doing it for your own experience of just having, less symptoms.
It's funny. So I've had my studio now for 20 years. And so I've seen kind of an arc, and I'm just putting it together in my head that in the beginning of when I started teaching prenatal yoga to now, I used to regularly have people be like, oh, I have to take a day off. Can I get an extension on my package? Because I'm having my amnio. And I'm like, wow, it just occurred to me, like, I have not heard that in years, but it was such a regular thing, 20 years ago. Wow.
Yeah.
Okay. I'm just
even
putting
like
that together.
10 years ago before this test. That you probably started seeing a lot, change around that time, because obviously as soon as the test comes out, it's not like every doctor in the US is ordering it. Right. So it takes a little bit of time to be adopted.
Are there other major tests that have changed in the last, 5-10 years?
So I would say even just within the non-invasive prenatal testing we're talking about for Down syndrome, sex of baby, even within that has changed a lot. So it started just looking at really Down syndrome, then adding more conditions like having an extra 1318, trisomy 1318 sex chromosomes. Now we look at something called microdeletions that are on there. So that's just a missing chunk of a chromosome instead of the entire chromosome. Those are more rare. Some of the tests, there's, a lot of different companies offer this. So it really depends on what company your provider's ordering from. But some of the companies will look at every single chromosome to see if it's extra or missing. So I think just within that has changed a lot in the last 10 years. Even I've been practicing for 3 years almost. And even just within that 3 years, we've had conditions added on to these tests. So it's definitely an exciting time to be in genetics of just looking at how many conditions are added. And there is testing that, when someone does an amniocentesis, depending on like what the reason for doing the amniocentesis, we're ordering different tests. And so there is, more recently testing available where we can actually look at, the whole exome, and I believe also whole genome, where we're looking at, instead of the chromosome level, we can dive deeper and look at actually the spelling of your entire genome. So that's really all your
cool.
genetic letters, which is
cool.
wild. You're talking about billions of letters to sort through. So I think that's kind of what we're looking at in terms of future of ordering more and more of those as the tests decrease in costs. I think that's always what ends up influencing genetic testing and what's actually available. Just because we can do it doesn't mean we can afford it.
Right. No, I get that. What are some reasons someone may want to opt completely out of genetic testing? I guess also, have you seen anyone nothing? They want nothing. Okay.
Yeah.
What are some reasons that, or I guess maybe it's a speculation, that someone may be opting out?
Yeah. And usually we chat about it kind of thing. So because I want to make sure oh, did I just not explain the test right? And are they just misunderstanding it? But yeah, some people might say me learning about a genetic condition that was coming up would change nothing in pregnancy for me and would really just increase my anxiety. So mental health is a big part of what I talk about too. So if they say, I just want to enjoy my pregnancy, what will happen will happen. If they're kind of coming from that mindset and they say, if I learned about a condition, it's really just going to increase my anxiety. And then I'm going to spend my whole pregnancy worrying about this. And if it's just going to happen anyway, I don't want to know about it. Some people, termination is not on the table for them. So if a condition comes up, it wouldn't matter. They also wouldn't necessarily want to take that time to prepare to have a child. They would rather just take things as it comes. So I think when people are expressing that that's, the mindset that they're coming from and that's what works best for them and their family, I'm like, okay, I'm so glad we talked about this, because some other places just order the testing. They don't really get what's called informed consent of sitting down and saying, let's explain this test. Do you actually want to do this? And some people are like, oh, is something, wrong or bad? Like, why am I sitting with you? And I'm like, oh, no, I meet with everybody in our practice. I sit down, we chat about this, see what works for you. And they're like, oh, okay. So I try to start with that with people of say, hey, I meet with everybody. This is, our flow in our office. So there's plenty of people that decide that it just doesn't work for them. And that's totally fine. Honestly, less work on my end, right? I'm not ordering the test calling results, right? But no, in reality, it's like, I want to support people and what's going to work best for them, because sometimes you do testing, a false alarm could come up. And at the end, they're like, I wish I never did this test.
Right.
Which I understand if you do end up having a false alarm.
So let's talk about your role as a genetic counselor, because it sounds a little more in depth than I think maybe some people think about, and that the fact that you do meet with everyone. So what is that role of a genetic counselor? And then how do you work with parents to help them navigate just, there's so many options, and then understanding the results. Is that what you do? Is that something their doctor do? Okay.
Yeah.
So can you talk about what that whole landscape looks like?
Yeah. So when I sit with people, a lot of our patients are what I kind of consider in-house patients, where they get all their pregnancy care with us, starting from, they call us, I have a positive home pregnancy test, all the way to postpartum. Some patients just come into us because their practice doesn't have a genetic counselor, and I'm kind of like their remote genetic counselor that they come to our office to chat. But for our in-house patients, we sit down at 10 weeks. I talk about the carrier screening, the non-invasive prenatal screening. We talk about the ultrasound. So really what we've talked about a lot today, I'm kind of like, okay, this is what I cover in a session. Mm-hmm. So I also go over, just confirm what was the first day of their last menstrual period. Okay, what's your due date? How was this conceived? Was this naturally conceived, IVF, IUI? Looking at, if it was IVF or IUI, okay, do you have a sperm donor, egg donor? What's the situation there? Are you the intended parent? So some people have a surrogate, where the pregnant person is not the intended parent. So to kind of just, making sure I have all the right information and I understand the dynamics, going through pregnancy history for that person that's pregnant. If there is one, I find if it's someone's first pregnancy, as you were kind of alluding to, we end up chatting much longer because there's a lot of new information to go over. If it's their second, third, fourth, whatever it is, I find the shorter the sessions go, the greater number of pregnancies or children that they have. So going through that just to make sure, is there anything that I should know about pregnancy history where any genetic conditions came up previous that I should be aware of. And then sitting down and going through a biological family health history. So going through the pregnant person's, and if it's the same, as the intended parent, going through like any health conditions, diagnoses that's come up for them, their partner, sperm donor, the biological families for them. So siblings, parents, nieces, nephews. And then I ask a lot of questions at the end, like anybody with a genetic disorder, right? Anybody done genetic testing for some reason? Anybody with cancer under the age of 50? So going through a lot of questions just to make sure that there's nothing that I'm missing. And so that's a big part of, when people think of like a genetic counselor, taking family history, taking a pedigree is a big, big chunk of that. And then, as we've been talking about, kind of going through the tests, what makes sense. I coordinate those tests, and when I get results, I call everybody out with that and touch base. So obviously most of the testing is going to come back normal. So I'm kind of I call all the normals. I know some places don't do that. Like I know when I go for GYN appointments and things like that, like they do testing. I don't hear back from them. It's like, okay, it's just normal. But I think with pregnancy, people really want to just hear and I'm waiting on these results. So I'm like, hey, have a good day. Everything looks good on my end. Any questions, and on the flip side, when things do come back that the testing says that there's a higher chance for a condition, I'm also the one calling and talking about that. And those conversations are obviously much different, much more in depth. And oftentimes I'm calling people with information. It's a very short phone call. And then they'll call me about, maybe half an hour later with a lot more questions. And we're kind of talking throughout the day. They'll call back. They have more questions. And that's what I really encourage, because when you find out information, it's really hard to then right away have the questions you have. The human brain just doesn't work like that. You're usually surprised.
You need to kind of marinate and let the questions come up. You seem like such a really supportive genetic counselor. I'm so happy for all the people that work with you, because, that's the kind of support one needs. Pregnancy can be very overwhelming. There's so much unknown, and to have a team that can offer you that empathy and handling things gently, and with grace, I think it's so important. We're going to take one more break. When we come back, what is one final tip or piece of advice you would like to offer new or expectant parents? Okay, we'll be right back. Okay, so you've worked with many expectant parents. Is there anything that you want to leave with them?
Yeah. Well, I feel like it's kind of an interesting question because I've never been pregnant. So it's kind of like, what advice do you have of something that you haven't experienced? So I think take this with a massive grain of salt. But I think it's, looking at your support network, and who's there and not being afraid to ask questions. I think some patients that are sitting with me, them or their partner, whoever their person is, and they're kind of like, well, I have a dumb question. I'm like, no, there's no dumb questions. Like, not at all. It's like, especially when it's your first pregnancy and you just don't know what to expect. And, you might feel like, oh, I have a headache. Like, I don't know. Can I take Advil? Like, that's not a dumb question. Like, I'm not a nurse. I don't know the answer to that, but, call the office and just ask. Like, there are no dumb questions. Like, we've heard them all, it's like, I hear questions from people and I'm like, oh, wow, I don't know. Well, let me go ask one of the nurses. We'll ask on the way out.
That's a great piece of advice because I don't think people, okay, maybe this is a little overstatement, but I think putting a lot of thought into your team is a really important thing. So I appreciate your statement on that. So thank you.
Yeah. And I love hearing patients' questions, and even like, I'll stick around just to hear the nurse's answer because, not shockingly after, spending an hour together here, like, I find pregnancy to be so fascinating and just so cool. Like, you're growing a human and all that goes with that, and just preparing to then take care of that human. And so I think it's such a cool process and scary and everything, right? It's everything all at once. It's exciting. It's scary. It's overwhelming. It's everything. So I think it's very, very cool just to be able to, I get this preview from patients, and I see everything. I see the patients that are just extremely nauseous and they're like, never be pregnant. And they're telling me this, and other people being like, I like, now I just feel so good. Like, I'm starting my second trimester. I'm getting that energy back. Like, so I just see everything. And I think it's just great when people are their own advocates and just saying, hey, if you feel like something's different, something's wrong, something, is off, it's like, call in and say, hey, this is what's going on. Like, should I be seen? Should I have like an ultrasound, like a heartbeat check is what we call them. Yeah. Just like a check-in. I think your body better than anybody else. And if you feel like something's off, it's like, then really express that. I think, any area of healthcare, but, I think especially pregnancy, you've got a lot, stakes are a little bit higher.
Yeah. So, and again, getting that support and getting your questions answered. Really good answers. So where can people find your work and your podcast?
Yeah, definitely. So I've been doing the podcast for over 10 years now. So I started in high school, and it's kind of grown with me with my career. I know. So wild. Cause some people are like, how old are you? It's like, but yeah, so, you can find it. It's called DNA Today. It's green logo. So anywhere you're listening to this podcast, and if you've enjoyed this conversation, there's a lot more, on DNA Today. We have over 230 episodes now. And there's quite a lot that's focused on pregnancy. Obviously, as a prenatal genetic counselor, I think those are some of my best interviews because I am also kind of adding to some of the content there. We have some great interviews, a lot where we dive into some of the testing I've talked about here, other type of testing that's available, different disorders. We've had some really cool celebrity guests on. I don't know if you're a Glee fan. We had Lauren Potter come on, who plays Becky Jackson. Yeah. And she shared her experience living with Down syndrome. And so, we have a lot of fun on the show and everything. And, I think our pregnancy related episodes are really interesting.
I did not hear that episode, but I absolutely am going to. I watched Glee.
She is such just joy. She was just so fun to record with. And after she was like, oh my gosh, I feel like we're good friends. And I'm like, I was like so starstruck during the whole interview. It was a challenge to interview her just because I was so excited. I was like, okay, I got to like reel it in a little bit.
That is what I'm going to be listening to later when I'm cleaning up my kitchen. I'm going to throw that one on. So totally. I appreciate this.
That's such an easy one to listen to because we're just kind of more chatting too. It's less sciencey, it makes it an easy listen.
Well, I wanted to thank you so much. I really enjoyed this. I'm so confident the community is going to listen to this and come away with confidence and knowledge, which is really what we're hoping people feel. So thank you so much.
Yeah. Well, thank you, Deb, for having me on. I appreciate this, especially the early morning as the coffee's flowing and just for you to provide such a great resource for people who are pregnant or planning to become pregnant. And it's just such a great thing because as we've said, it can be a very overwhelming time. And so it's just so great that you've built this community and you're sharing so much content with people and you're creating that community.
Thank you.
This has been an episode of Yoga, Birth, Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.